There is a great need for help in making the early, acute, vital treatment decisions for people who are suffering stroke right when it occurs and they show up to an ER. It requires expertise, and what we found is that if you apply that expertise, we're more often able to treat patients, we are more accurate with the diagnosis, and we're seeing better outcomes. So how do you spread the expertise around in order to get patients who show up at any hospital, and we're in a rural part of the country, and we're just not going to have that neurological expertise available. So there's nothing really fancy about it. It's just getting your expertise out to the patient where, a stroke doctor like myself can do my own exam, take my own history, and get a good understanding of whether or not I'm making the right treatment decisions for patients. We started work with Aberdeen with a pilot to see how it would work, and now we're creating kind of a stroke system of care that is with Aberdeen, South Dakota, St. Luke's Hospital as the hub of that stroke system of care. So each of these smaller hospitals might be able to offer some aspect of stroke care, but not all aspects. And so we do what we can at those sites by bringing the expertise into the site. And when it's appropriate for patients to stay close to home, then they can. And but if they need a higher level of care, we're helping with those transitions. This treatment decision, this early treatment decision, is the whole reason that telemedicine for stroke has just grown like wildfire, because you need that decision to be made in a timely fashion, and we're talking minutes. So there are two forms of treatment available for stroke when it's occurring that I call rescue treatment, to try to reverse the stroke before the damage is permanent. So the first one is a clot dissolving treatment called tissue plasminogen activator, or TPA for short. It's just a drug given in an IV. So and the sooner you give it, the more effective it is. We have, from the time the symptoms start to the time that we can no longer give them medication, is 4.5 hours. So, and the earlier in that time window that you arrive to the hospital and get the treatment started, the more effective it is. So literally, every 15 minutes is a 5% reduction in mortality from stroke if that treatment is given just 15 minutes earlier. So very important to get in and get treated quickly, make the right treatment decision, get the exam done, that sort of thing. The second level of treatment, if the stroke is caused by a blood clot in a larger blood vessel, that drug might not be enough to completely dissolve the clot. It might help, but it might not be enough. In some cases, we have to move patients from that rural site where we don't have this second tool to a larger city hospital where they can do what we call mechanical thrombectomy. And that's where we go up with a catheter through the blood vessel system all the way up to where the clot is, and remove the clot mechanically, either with something called a stentriver, where a stent is opened up and clasps down over the clot and you pull the whole thing out, or with a device that acts with a suction-like mechanism in order to pull the clot out. Either are very effective. 20 to 30% are going to be hemorrhagic strokes, where there can be bleeding into the brain from a breakage of a blood vessel. Easily determined, though. A CAT scan will show an area of bleeding very clearly. On the other hand, when it's the other kind of stroke, where the damage isn't permanent yet, you aren't going to see a change on CAT scan. You might see a normal CAT scan. So we do that CAT scan, and if there is no blood seen on the CAT scan, then we're able to deliver treatments that we are talking about.